Hello, Dr. Arir.
Hello, can you hear me?
Yes, we can hear you. Can you hear us?
Is it loud and clear? Is my voice clear enough?
Yes,
Because I
it is
have the
clear.
AC on and it's might
Loud?
be. I need to turn on the camera, right? Okay. Video. Okay. Start video.
Dima, you can start.
Yeah. Yeah.
I think we can start now. Warm greetings, everyone, and welcome to our webinar today on advancing meningitis surveillance in the Eastern Mediterranean region. I'm Dr. Dima Al-Bakri, a public health technical officer in the Disease Control and Prevention Unit in the Public Health Programs in Infinite HQ based in Amman, and I will be your hostess for today. We are truly delighted to have such a diverse audience joining us from different parts of the world, representing public health institutes, academia, laboratories, ministries of health, international organizations, or even interested individuals who are simply here for their interest about the issue. I'm pleased to share that we have more than 400 registrants who registered for today's session, which highlights the importance and the urgency of this conversation we're having. Your presence reflects the growing recognition that meningitis and other invasive bacterial diseases remain among the most pressing public health challenges of our time. As many of you know, meningitis is a devastating disease. It strikes quickly and can cause death, and it often leaves behind lifelong consequences, such as hearing loss, seizures, and even cognitive impairment. Each year, hundreds of thousands of people around the globe are affected, and the burden is particularly heavy in low and middle income countries where health systems already face significant strains. While vaccines have advanced, treatments also have improved, but the fact remains that meningitis outbreaks are still a serious threat. Defeating meningitis requires a global vision, like the WHO roadmap, which we will discuss more thoroughly today. But its success also depends on regional and national action. Today's webinar reflects this specifically. We will first hear about the global burden and roadmap, then we will explore a regional initiative from the Eastern Mediterranean region called the MenMap, and finally, we will have a panel that connects international, regional, and country perspectives. Our aim is not only to share knowledge, but to spark dialogue. Please note that all participants will remain muted during the session to ensure a smooth flow. However, we warmly encourage you to use the Q&A box below and even the chat box throughout the webinar, as you will bring your questions into the panel discussion with us. Once again, thank you for being here with us today and for your continued commitment to advancing public health. First and foremost, our first speaker for today is Professor Dominique Cougant. She's a chief scientist at the Norwegian Institute of Public Health and a lifelong head of the WHO Collaborating Center for Reference and Research on Meningococci in Oslo. She's also part of the WHO task force supporting defeating meningitis by 2030 initiative, and she has been involved in vaccine research, especially against meningococcal diseases. Her journey and contributions are far too extensive to capture in this short introduction, but we are truly grateful to have you with us, Professor Dominique. So the floor is yours to hear about the global burden on meningitis and more on the WHO roadmap. You're muted, Professor. Ammar, can you unmute, please?
Prof. Dominique, you are muted.
Can you unmute her from your side?
No.
Oh, okay. You're unmuted now. Yes. We can always expect some technical difficulties in online presentations. That's all
I'm
right.
very sorry, but I'm not used
It's all
to
right.
Zoom at all, and I
It's
don't
okay.
know how to share now. Oh, this is terrible.
It's all right. If it doesn't work, Ammar can share from his side.
Yeah, maybe because now I have lost my file.
Okay.
Okay, so if you want to share my slides, it will be very nice. Thank you very much, and thank you for the kind introduction, and sorry for not being very good in Zoom. But next slide, please. We will talk about meningitis, but meningitis is not only meningitis, because a number of other forms of the disease are caused by those meningitis causing pathogens. And this is illustrated on the picture on the top of the slides of this child affected by this septicemia. If we looked at the data provided by the Institute of Health Metrics and Evaluation, it is estimated that meningitis is occurring in all countries in the world, with an estimated of 2.5 million of new cases every year. And these are resulting to about 250,000 deaths. The highest burden of disease is occurring in babies and young children. And as shown on the map on the bottom here on the right, the highest overall burden of the disease is occurring in Africa. The case fatality rate is around 10 to 15%, and the disease may occur as single cases, it may occur as cluster, it may give community outbreaks, and also epidemics. Epidemics have occurred in all regions of the world, but the major epidemics of meningococcal disease are occurring in the meningitis belt of sub-Saharan Africa, and this is across the whole continent. As Dr. Dima has already told you, not only the disease is a problem, but it's the sequelae that are occurring after patient has partially recovered. And this is often hearing loss, cognitive disability, and limb lost. And this is occurring everywhere. And all the bacteria are also giving sequelae. But the highest proportion will be due to Streptococcus group B, which are estimated to resulting in 32% of sequelae. Pneumococci, 25%, and a bit less for meningococcal meningitis, around 15%. And the thing is that the people living in low-income countries are worstly affected by this sequelae because of the situation. The impact, the economical impact is enormous. Next slide, please. This is showing the result of the study by Orts and Spitt that was published in 2018, trying to look at the agent responsible for bacterial meningitis in different parts of the world. And for the part of the world where data is available, you can see there are two pathogens that are sticking up. It's meningococcal meningitis or Neisseria meningitidis marked in green, and Streptococcus pneumoniae marked in violet. And these are dominating everywhere. And in addition, we have shown here in yellow Haemophilus influenza occurring at a much lower frequency, and this is due to the universal introduction of the vaccine against Hib starting already in the 1990s. Next slide, please. Here is shown the incidence of the disease per 100,000 in the children less than 5 years of age. And these are data from the global burden of disease in 2019. And again, you see the enormous burden of the disease in the sub-Saharan Africa, but also in Southern Asia. Next slide, please. The situation is quite serious, but still a number of things have been achieved in the past 30 years. Here are data showing the comparison of the cases and deaths due to meningococcal meningitis due to different organisms. And you see the number of deaths has been significantly reduced, basically for all pathogens, but maybe very significantly for Neisseria meningitidis. And this is probably as a clear result of the introduction of the vaccine. The number of cases have been also reduced for Neisseria meningitidis, but not such a strong reduction was seen for Streptococcus pneumoniae. Next slide, please. This is showing data that you probably know very well. It's the burden of meningitis in North Africa and the Middle East. As you have seen on the previous slide, the incidence of disease is not as high as in sub-Saharan Africa. And also there has been a significant decrease in the number of reported cases in the region in the past 30 years. However, the number of daily is still around 70 per 100,000, and the incidence of meningitis of 22 per 100,000, and 1 per 100,000 die of meningitis. But there is also a very strong variation through the region, and especially with Afghanistan, with being a proportion that is mainly 10 times higher as the rest of the region. I will now move to the global strategy that has been developed to defeat meningitis. This started in May 2017 by a call to develop a vision for ending meningitis. And this was in the UK, in Wilton Park, where a group of experts and various stakeholders met and set up to start with this global vision. In September of the same year, there was a call amplification in Ouagadougou in Burkina Faso, with both partner and manufacturer of vaccine meeting and urging to develop improve vaccine and make them timely available. And country and WHO were encouraged to support this initiative to make meningitis a priority at the global level. The call was further amplified in October 2018 in Dakar, and then reiterated in October 2019 in Yaoundé. And this was very much focused on the meningitis belt country. Next slide, please. From there, a global strategy to making a world free of meningitis was developed. This global strategy had three goals. The first one was to eliminate the bacterial meningitis epidemics, then to reduce the number of cases by 50% and the number of deaths by 70% using vaccine-preventable bacterial meningitis, and then to reduce disability and improve quality of life after meningitis due to any cause. And this third goal was something very innovative because it's really looking at a larger vision regarding how to fight meningitis. This global strategy is based on 5 pillars. One is to prevent and control epidemics. The second one addresses diagnostic and treatment. The third is disease surveillance. And the two last, which are quite innovative, was support and care for people affected by the meningitis, and then advocacy and engagement. The whole global strategy is based on research, really looking at generation of evidence regarding meningitis and development of new products, then involving the policy and implementing the roadmap at the global, regional, and country level. Next slide, please. So the roadmap has been developed using 3 types of activities. First, setting up a technical task force that started in 2018, which involved a group of technical partners engaged in the meningitis control. And the task force is also involved in the coordination of the development of the roadmap. The roadmap also included conducting a baseline situation analysis to try to map the problem with the disease, where critical gaps in research and implementation are occurring. And the third point is really conducting an iterative consulting process with diverse regional and country representation. This is quite important to involve experts, but also health and disability people and the civil society. So the multi-partner coalition is quite important. Next slide, please. So what is the expected impact of the roadmap? First, with the goal 1 on eliminating the meningitis epidemic. This will be really a huge public health achievement. The goal 2 is reducing the number of cases by 50% and the number of deaths by 70%. This is expected to result in 2.7 million cases averted and more than 900,000 deaths. And then reduction in disability and improvement of life quality is expected to result in more than 800,000 sequelae meningitis averted. And altogether, more than 75 million of daily awarded. Next slide, please. So the roadmap was presented to the 73rd World Health Assembly in November 2020, where it was endorsed as the first resolution of meningitis prevention and control. The roadmap was approved, and there the launch officially was made in September 2021. And the roadmap is focusing on organisms that are responsible for the majority of acute bacterial meningitis cases. This Neisseria meningitis, Streptococcus pneumoniae, and Haemophilus influenza. All three are preventable by vaccination. And the fourth one is Streptococcus aglatea, group B, strep B, for which vaccines are under development. Next slide, please. The roadmap is expected to have a huge impact of meningitis, but it's also having a general impact on public health by limiting the number of cases caused by this meningitis pathogen. It's not only restricting to meningitis, I tried to show on the first slide, it's also all other forms of disease caused by those pathogens. It's also limiting the rise on antimicrobial resistance, and it will lower the burden on health system, and especially in case of epidemics. And also because intervention on meningitis are integrated, surveillance, vaccination, management of sequelae will be improved. This will help on the health expenditure. It will help to get people out of poverty, improving the economics of the household, and in the same link, improving education and probably having a role on gender equity. And this is some of the goals of the Sustainable Development Goals that will be reached. Next slide, please. How the work is being performed. I think I missed one of the slides, but it's okay. This is using one aspect that WHO has developed. It's to make national plans for meningitis. And WHO has been developing a manual for helping the country on that matter. Next slide, please. So how those national meningitis plans are developed, it's basically to start establishing a core group of people who will be in charge of the development, making a situation analysis, and develop a draft of these national plans. And they're involving many different stakeholders in different consultations, and then to present this national plan to a high level of for validation, and ensuring that the political system will be involved into it and will lead the implementation of the plan. Next slide, please. The first focus has been in Africa, and their meningitis landscape risk analysis has been performed to try to identify which country has the highest burden of disease and how the health system are affected and need to be strengthened. Then the continent has been, or the Afro region has been set up in 3 levels of risk, high, medium, and low, as shown on this slide. Next slide, please. This risk analysis is used to set up development plans for introduction of the new vaccine, the pentavalent ACWYX vaccine against meningococcal disease. And this is showing you risk assessments that have been conducted in March 2025 in 7 of the countries in the belt. Other countries are also planned to have their risk assessment made. And there have been applications to Gavi that are in progress. Niger applied for the pentavalent vaccine in September 2024, and this has been approved by Gavi. And there is now 10 additional countries who have been applied to Gavi. And there are dialogue with a number of new countries also to send application. This is quite important to replace the MEN-I vaccine by the pentavalent in the region. Next slide, please. Not only if the main focus has been on Africa, it's because of the epidemic there, but not only Africa is involved. There is a lot of work that has been done in South America. There has been also landscape analysis to identify priority country to be receiving the support. And there I think it's Brazil, Chile, Costa Rica and El Salvador that have been the priority country. And there WHO has been organizing a number of regional workshops to inform about the roadmap and to help publishing documentation and really to move forward the implementation of the work there. Next slide, please. There is also some work done in the Eastern Mediterranean region. WHO had a retreat in Cairo in April 2023, and this was involving 3 levels: national, regional, and global. This was made to outline the regional framework for Eastern Mediterranean region and to set up communication, research mobilization, and partnership plan. And all these activities have been made at all 3 levels. And there are ongoing completion of the landscape analysis and development of a regional plan to implement the roadmap in the region. And this is also similarly underway in the 3 other WHO regions in Europe, Southeast Asia, and Western Pacific. Next slide, please. The technical task force has met regularly since the first meeting in 2018. The meetings have been usually in Geneva until the work starts to be in progress. And there we had the 9th technical task force meeting in Amman in June 2023. And there the next meeting, the 10th meeting, will be next week in Chile. So really the different WHO regions are really focused on now. Next slide, please. In addition, there has been set up the first high-level meeting to defeat meningitis by 2030. This meeting was held in April 2024 at the Institut Pasteur in Paris, and that was under the high patronage of the President of the French Republic, Emmanuel Macron. This was a very successful meeting where many commitments were made to really support the roadmap, both politically and financially. And I understand that the next high-level meeting to defeat meningitis will be held later this year, so it's under plan. Next slide, please. And this is my last slide. It's really a number of the strategic goals and milestones have been gradually achieved. It's WHO says that about 50 of the 99 milestones have now been achieved. So it's a good progress in the first years of the roadmap. And there is a political will and resources have been formed, and also the civil society is engaged. Regarding the various pillars, for the pillar on prevention and epidemic control, the pentavalent vaccine has been already used for outbreak response in 2024 in Nigeria and Niger. And Niger will be the first country to introduce mass vaccination in 2025. And that means all the 1 to 19-year-old will be eligible to get the vaccine. Regarding Pillar 2 on diagnostic and treatment, the guidelines have been published in 2025, as you see on the right of the slides. And regarding Pillar 3, for disease surveillance, a working group has been established. However, it has been some delay because of the withdrawal of the United States from the WHO, and this pillar or this working group was led by people from the CDC. But this is being reorganized, and we believe this will move very much forward. I'm not talking about the two last pillars, number 4 and 5, because I am not so much informed about this, but I know the work is ongoing. And to end up, I really want to thank you for attending and hearing me, but I want really to give a special thanks to Dr. Marie-Pierre Preciosi, both for providing the slides, some of the slides for this presentation, but also by leading the work with the roadmap in a very strong manner, very good. So thank you very much.
Thank you so much, Professor Dominique, for this comprehensive overview on the global landscape and also on the roadmap guiding the international efforts. Your presentation has set the stage to our discussion today, where you not only highlight the magnitude of the global burden, but also you gave us concrete opportunities and partnerships that can help us collectively move closer to the 2030 targets. So thank you again, and we'll hear more from you during the panel discussion. Up next, allow me to introduce Professor Mohamed Khair Taha. He is a professor at the Institut Pasteur in Paris, France, and he is the president of the European Meningococcal and Haemophilus Disease Society and the head of the French National Reference Center for Meningococcal and H. influenza and the WHO Collaborating Center for Meningitis. His extensive research covers epidemiology, pathogenesis, and vaccine development for IBDs. It's a privilege to have you with us here today, Professor Khair, and we look forward to learning from your wealth of expertise and experience. So the floor is yours. You have 15 minutes. Thank you.
Thank you. Thank you very much. I'm really glad to be here today with all of you, and I would like to share some of the work that has been conducted within the MenMap project. This presentation is mainly the presentation that made by Dr. Lamia Al-Karshi during the biannual meeting of the European Meningococcal and Haemophilus Influenza Disease Society that was held in Crete last May. So this is really all credit for Dr. Lamia Al-Karshi. We will focus on the work within this project, and mainly in the 3 countries in the Near East, which are Jordan, Egypt, and Iraq. And first of all, in the next slide, you will see some of the information and disclosure. This project was funded by Sanofi. And you have here the names of the people who were involved in this project in the steering committee, and in scientific committee, the chair is Professor Ray Borough in Manchester in the United Kingdom. And you heard from Professor Cogant, and you have all the names here that are involved, but of course, most of the involvement are from people working in the field in the three countries, Jordan, Iraq, and Egypt. So in the next slide, I'll set up the scene with some information of the background. This is mainly surveillance for invasive bacterial diseases, not only meningitis, but all forms of these diseases that are mainly caused by three bacterial agents: Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenzae. The focus will be on the MENA region, Middle East and North African region, but I'll focus, for instance, on the three countries mentioned here in this slide. And as you can see, we have implemented several sites in these three countries to use real-time PCR for the diagnosis and the grouping, typing of these three agents. So we have four governorates in Jordan, 4 governorates in Egypt, and 5 governorates in Iraq with 8 sentinel sites. You can see the distribution of those sites on the maps of the 3 countries. I'll show you some of the results that we have obtained during the first year of this project. The first piece of information here is the case definition. And we use this case definition, which is the identifying of one of the 3 agents, Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenzae, from a sterile site. And we mainly used real-time PCR. The target population was children from aged from 1 month to 18 years of age. And we used, as I mentioned, real-time PCR. Culture was also used for some samples, but mainly it's real-time PCR for the 3 agents. Here you can see the gene targets that we used first to identify the species. So the gene HPD for the identification of Haemophilus influenzae, SOT-C, and or CTRA for Neisseria meningitidis, and LIT-A for Streptococcus pneumoniae. After this first identification by PCR of the species, if it's Haemophilus influenzae, we went further for the serotyping, and mainly Haemophilus influenzae serotype B. For the Neisseria meningitidis, mainly we focused on serogroups A, B, C, W, Y, and X. And for instance, for Streptococcus pneumoniae, this was based only on the identification of the species. At this stage, there was no serotyping. On the next slide, you can see the overall results that obtained from the 3 countries. As you can see, overall, more than 2,000 suspected cases were tested, and 191 cases that accounts for 9% of those cases were confirmed to be bacterial meningitis. Unfortunately, we're still focusing only on CSF and meningitis, but one of the aim of the project is really to enlarge the types of the samples to go beyond the CSF. As you can see here, the distribution of the cases according to age groups. Most of the cases were among children under the age of 5 years, and we still have some cases between 6 and 14 years, and much less cases between 15 and 18 years. This is something very similar what we would expect for acute bacterial meningitis in children from the age of 1 month. On the next slide, you can see here the distribution per country and per agent. As you can see, for the 3 countries, Jordan, Egypt, and Iraq, the most frequent agent that was identified was Streptococcus pneumoniae, and then you have a few cases with Haemophilus influenzae and Neisseria meningitidis. On the next slide, we focused here on the cases of acute bacterial meningitis. As I mentioned, we went further in grouping for Neisseria meningitidis. So among the cases of Neisseria meningitis, indeed, there were very few cases of Neisseria meningitidis. One was Men-A, 2 were Men-B, and 1 was non-determined. And there were 15 cases of Haemophilus influenzae that were Haemophilus influenzae of serotype B. Those cases were detected between December 2023 up to November 2024. As I mentioned, this is the data from the first year of the project. On the next slide, we also implemented an external quality assessment during this first year. And indeed, we are conducting a second exercise currently for the 3 countries. The exercise consisted of the distribution of 7 samples. Here you can see the expected identification of these samples from E1 to E7. And you can see here the performance of the 3 countries. So for the identification of the species, 86% score was achieved by the 3 countries. The scores were a bit less for the genotype, for the group, and for the serotype. This was ranging between 83%, between 50% up to 83%. So there are probably some areas for improvement that will be addressed during the second year. In conclusion, after this first year, what were the key findings? Strep pneumonia is the most prevalent pathogen. Iraq had the highest percentage of confirmed cases. Children under the age of 5 represent the majority of confirmed cases. The next step will be to continue to strengthen regional collaboration, to focus on pathogen characterization beyond the serogroup and serotype, and of course, implement further external quality assurance studies. As I mentioned, there's one which is currently running in the 3 countries. And I think this is my last slide. And with that, I would like to thank you for your attention, and I will be happy to take questions during the panel discussion.
Thank you for your presentation, Professor Taha, and thank you for presenting the regional initiative as an example from as an example that can teach lessons to the global level, and for presenting its early findings. Your presentation has illustrated how regional collaboration in the EMR is building laboratory capacity, is strengthening surveillance, and is generating valuable data where we had data gaps. And you also highcased how we can both benefit and contribute to this collective effort. Thank you. As we move onward to our panel discussion, allow me to introduce Dr. Arij, who will be joining us in addition to Professor Dominique and Professor Khair Taha. Dr. Arij Al-Shobaki is a field epidemiologist from the surveillance unit at the Ministry of Health in Jordan. She brings valuable national experience from her engagement in the MenMap initiative. She has been directly engaged in the activities and has played an important role in strengthening meningitis surveillance and laboratory capacities at the national level. So her insights will be especially valuable in connecting the broader strategies with the realities of implementation on the ground. Again, a reminder to our audience, please share your questions throughout the discussion in the Q&A box at any time, so we will bring them into conversation as we go along. So Dr. Arij, hello. I wanted to ask you from a national perspective, what has Jordan learned through its engagement in the MenMap initiative, and how has it influenced your surveillance systems?
Hi, hello, everybody. Thank you for including me in this very important discussion on an episode of a very successful WEbi series run by MFNet. Well, what we learned, Jordan has always been, we always strive to be pioneers to be at the avant-garde of the science of medical investigations and outbreak investigations. So, and we have been actively seeking to modernize our science surveillance approach, not rely on traditional measures. This project itself it's a work in progress. It's consistently improving. It's a 5-year project which we are working on. Every year there's improvements, reviews, and reevaluations of our protocols and the approaches used. This showed us that surveillance is not static. It is a living, learning organism that it needs to be kept alive by strong partnerships and sustained resources, and the commitment from everyone involved, from every stakeholder, from every health worker at the clinical level to the national level. It also showed that standardization matters. Now, a thing about this project, we do have our own protocols, our standards, and we have a strong central surveillance program for respiratory illnesses as part of the PIP, the Pandemic Influenza Preparedness Project. But so this for the MenMap for us was a way to complement or augment our already established central surveillance program. So, and with this standardization, this cross-regional standardization, and you're providing us with a secure data portal and a dashboard. It improved the completeness, comparability, and the timely sharing of Jordan. These practices that we're learning here in this project, we can apply across other priority syndromes and other, even now, as we are introducing the PCV vaccine, the novel PCV13 vaccine here in Jordan, we are looking forward to utilize this part of the surveillance system to test, to build on our vaccine policies and preparedness, and to test the effectiveness of inclusion of the new vaccines. So all is also trying to ultimately create a more robust and accurate surveillance. Over to you.
Thank you. Thank you, Dr. Elij. It's really interesting to see how the national level had benefited from such a program, and especially with the vaccines being introduced. And continuing on this, I would like to move to Professor Taha. How do you think can the MenMap serve as a model to other regions facing similar challenges in meningitis surveillance?
Thank you for the question. Well, I probably must say here first that we had already completed another similar project that was also funded by Sanofi in the 3 northern African countries, Tunisia, Algeria, and Morocco. Yeah. So one of the aspects that we would like to see now is how to link the 2 networks, the one in MenMap, the 3 countries, Egypt, Jordan, and Iraq, to the 3 northern African countries. And most likely, it would be very important to include other countries from the region, say Syria, Lebanon, Gulf countries, and other countries, to enlarge the surveillance in the whole region. I think what is really important, if I can say beyond the question, is to improve the exhaustiveness and the representativeness of the surveillance in these countries. And a second step in the future will be to link this network to other regional and continental networks, such as the EMGM, for example, in Europe, or in sub-Saharan countries. So this would give us an overall view of what is going on with these infections, these invasive diseases at a global level. I don't know whether this answered your question.
Yes, definitely. So you don't only call for for this model to be replicated, but also to expand the current model to include as many countries in the region. I think this is very important, and to use this platform of this Webi series to call for collaboration and expansion of the network. Thank you, Professor Taha. As we are being optimistic, I wanted to go back to Professor Dominique and go back to the gaps we're facing. What do you think are the biggest gaps in global meningitis surveillance, and how can collaboration and collaborative efforts help address these gaps? You're muted.
It's a mute.
Okay. Sorry. Yes, what are the gaps? I think the gaps are opening at many levels. And we have some surveillance data, but one of the main problem is that it's meningitis. It's not all kind of disease that are caused by those pathogens. We have also a number of problems with some countries that are reporting only in children under the age of 5 and not really on the whole population. And this is quite important because there is some changes in the dynamic of those infections. But the gaps are at all levels, and it's mainly to start with taking samples of the patient. In number of countries, it's very limited how much cerebrospinal fluid samples are taken. We have a gap regarding what kind of tests can be used locally in the lowest level of the public health facility and the laboratory. We are lacking really diagnostic tests that can be used at the lower level of where the patient are. We are talking, and Mohammed talked about PCR, but still it's not a method that can be used and the local physician. And then we have a problem with transport of the specimen. Many countries cannot transport efficiently specimens and to be analyzed at high-level laboratory. And if the specimens are transported, it's not always that they are able to generate pathogens that are surviving. And then laboratory capacity is quite a problem in some countries. To continue on this list, it's also reporting how the data are reported from the lowest level of surveillance to the national level, and really how you can get some data that are complete. And we see that in some countries, the level of surveillance it's so low that it's probably quite an underestimation of really the number of cases that are occurring. So I think the gaps are at all levels, and it's difficult because it's different problem in different countries. So I think we need to work on really sustaining all these aspects, and really reporting is important. And it's also important to see what kind of progress we are doing on the global level. Thank you.
Thank you so much, Professor Dominique, for a very, I think, holistic approach to the question. You started with the data collection at the clinical level and up to the reporting stage and all the chain in between. So I think this is very interesting for us to highlight on and to work together on collaborating and strengthening this area. And since we're speaking about the clinical data collection, I want to go back to Dr. Arij and tell us at the national level, how do you think the role of frontline health workers and hospital staff in supporting data collection and outbreak detection?
Well, they are the first link in the chain. They are the first responders, the front line. They begin the entire process. There are early warning systems. They are the ones who recognize, identify triggers for outbreak investigations or any unusual event. Sorry, I was writing in my notes. Their most important role is one of the most important functions of surveillance is early detection. So early case finding and the communication. The one thing about the project, it strengthened the communication between the lab and the clinicians and the healthcare workers and social workers at the hospital. So we developed this a conversation, like, what are the immunizations of this child or patient? What's the information that's being gathered about each case deepens our understanding and strengthens community response to the problem itself and raises community awareness. So they are not just collecting data, our frontline workers, they also contribute to their own communities, and they are raising awareness and putting it on the forefront, teaching people how to deal with similar situations. So, and this continuous feedback and this collaboration and there's this feedback between the decision makers here at the ministry and the frontline workers. They feel involved. And with the continuous training and involvement in the data collection and the release of results is also very important. So it's the importance of let's say surveillance starts at the bedside, and this project helps us to it's giving them a backbone, let's say, or a structured approach to surveillance. Oh, sorry. Over to you. Thank you.
Thank you, Dr. Arij. I liked what you said, that surveillance starts at the bedside. And also Professor Taha also, when he presented the data, emphasized that the importance of this data lies from the people who started collecting it and people at the Central Public Health Laboratories. Back to you, Professor Taha. How do you think can these laboratory networks and even reference centers in the region be further strengthened in order to ensure sustainability?
Well, I think, as I first mentioned, the expanding of this type of project is really important. However, what is really important to have a sustainable system is to implement national reference centers. That means each country you have a central reference center, say in Jordan, in Amman, who will receive the samples from the peripheral hospitals. So the mission of the reference center is not diagnosis, because the diagnosis should be made next to the bed of the patient. So the national reference center will be involved in the surveillance, and the second step will be to link the microbiological data, surveillance microbiological data, to the epidemiological data in terms of age distribution, mortalities, clinical forms, and others. So in this way, you will go further in having a very sustainable system and strong system in providing representative situation of what is really going on with these diseases. So really, the reference lab is a major piece of it. And I think you can see the situation in many European countries. In all European countries, you have a reference lab, one reference lab per country that is really involved in the microbiological surveillance, not diagnosis.
Thank you. This is really interesting to keep in mind. As we're looking forward and moving ahead, Professor Dominique, How do you think we can ensure that meningitis remains high on the global health agenda, given that there are other competing priorities like climate change and emerging diseases as well?
Well, I think meningitis is a very special disease because of people in the world are quite aware of meningitis. If you go in sub-Saharan Africa, you have really people are so afraid of those epidemics because it's really taking over in a very short period of time the life of many people. Even in Europe, in our country, in Norway, if you have one case of meningitis and with a patient that died, this is a headline in the newspaper. People are really very much concerned about this kind of disease. So I think what is important is to keep talking about it. It's really, the roadmap is really keeping the focus on what is happening. And the roadmap has really put up the different aspects of meningitis from the clinician to the public health and really to on the global level with the WHO. And there are now some fundings that are available to really drive this roadmap, and especially with implementation of the vaccine. And vaccines are there, not for all. We don't have still a vaccine for group B streptococci, but the others are here and they have to be used. And I think what we have seen in the past 30 years, it's really the impact of vaccination. So I think it's a motivation and really to have the focus of the people who are engaged in it to continue the work. And there is some good chance that we are achieving because we're on the way and we need to have good surveillance. We need to show also that it's working, that we are reducing the number of cases. And that means we need to have the data for it. Thank you.
Yeah, so it's a full loop. We have gaps in data, we fill the data, we talk about the data, and you keep people engaged, and so it's a full cycle. Thank you, Professor Dominique. Dr. Erij, back to you. I wanted to know, as we're looking forward, what additional support or partnerships would be most useful to sustain and expand the progress that has been made under the MenMap, including trainings and capacity buildings, etc.
Well, the priority here is to build something that will last. We're not looking for a short-term project that will end as soon as the funding is ending or the project itself, the plan has ended. We're looking to enter the long run. And so basically ensure financial sustainability and stability, building across other sectors such as building partnerships with the private sectors, as we did during the COVID-19 pandemic. We utilized biolabs and midlabs and these private laboratories. But at the same time, we are now have strengthened our core or central laboratory core capacities for molecular epidemiology. So which is expensive. Molecular epidemiology, anything that has molecular in the name, it's quite expensive. So we would like to also not just in Jordan we have 4 Sentinel sites. We would like to looking forward to strategically expand this coverage, to add more sites, to improve the geographic and representativeness, and maybe even improved age groups that are represented in this project. maybe even conduct joint readiness exercises across the regions, like with not just sharing the information, but joining together in responding and creating plans to, especially that we are not, we are part of the, I call it, well, it is the Fertile Crescent, Iraq, Jordan, and Egypt, and we are geographically close to the meningitis belt, and we have mass gatherings and religious travel from the two cases that were reported in Jordan this year were actually related to Umrah and Hajj traveling. So anything, so this regional collaboration and maybe find something not just on a national level but on an international level to sustain us would be beneficial. This
Yeah, it's interesting. I'm getting a trend of messages from the three speakers, and we're emphasizing on the call for joint efforts and collaboration. And interestingly, even in the chat box, I'm trying to just read quickly. Some people are already calling for collaboration and are interested to join such efforts. So I already see the trend in what you're saying. Yeah.
the pandemic doesn't respect borders. So what's the difference if there's drawn borders between Jordan or Iraq or Syria or Egypt? These are not actual real borders. So we need this, as I said, not just on a national level, on a regional level, and hopefully we are better prepared and strengthen our national public health security to the point that we can not only respond to epidemics or outbreaks on a national level, but on a regional level too. Over to you.
Thank you. Thank you, Dr. Arij. Professor Taha, as promised, I'm trying to go through the audience questions, and there has been some questions regarding your presentation. So there was a question regarding Egypt. It says that if Egypt has the majority of cases for Neisseria meningitis serotype B, what could be some recommendations to control Neisseria meningitis infection in Egypt? And was the EQA for PCR or culture samples for pathogen identification?
I think for Egypt, it's really interesting to talk about serogroup B, Neisseria meningitis. I have been in Egypt this year, and that was at the time where Egypt launched and implemented the MenB vaccine. So I think in Egypt and in general in other countries, what's really important is to have a representative and exhaustive surveillance in order to inform the implementation of vaccines. Of course, it seems that Egypt is mainly, as other countries in Northern Africa, the data from Tunisia, Algeria, and Morocco, mainly Morocco, and especially Morocco, also pointed to the high prevalence of serogroup B. So it seems that serogroup B vaccination is of importance in these countries. But again, I think we need to be confident about these data with much more exhaustive. We can talk about how to be sure about the exhaustiveness and the representativeness of the system, if there's any question on this. But I think this is really very important. The second step will be, if this is really confirmed, we need to know what is the proportion of isolate that are covered by the serogroup B vaccines. As you may know, these vaccines, unlike the capsular-based vaccine, will not cover all the isolates. So the second step will be to see how what is the proportion of coverage. So I think, again, we have to enhance and to improve the surveillance system. If this is confirmed, MenB vaccine would be of importance to be considered. And this is the case, back again to Egypt, this was the case this year in Egypt, where they introduced the MenB vaccine.
Thank you for the recommendation and for the insight on what's actually happening in Egypt. Thank you, Doctor. Professor Dominique, there's also some interest from the audience about the very low rates in the map you have shown in Canada, USA, and China. What do you think are the causes of success to have the lowest rates of meningitis globally?
Well, the rates are low because there has been some effort done for many years, really, by using vaccines, and especially in Canada, for example, the serogroup C vaccine has been used for quite some years, and now I use tetravalent vaccine and also the MenB vaccine in some regions. And we know also that China has been using polysaccharide vaccines against Men A and Men C for many years, and are now expanding using conjugate vaccine also for the major serogroup. So this is quite a result of this vaccine usage. It's no doubt about it. And this is what we have seen also the impact in Africa after the introduction of Menafrivac. Really, even if we still have some epidemics, the number of cases is at different levels than we had before the introduction of the vaccine.
As we're saying about the variability of, as we're saying about vaccines, there's also a variability of how much they're available across the regions. And I think this question is for any of the panelists who want to respond. I also read one of the questions from the audience saying that also there's a variability in the availability of lab kits. So how difficult is it to ensure health equality in such different variable availability of vaccines and lab kits across the different regions?
I did not understand your question. I'm sorry. What is the variability of
availability of vaccines and lab kits, etc., across different regions? How do you think we can maintain some kind of health equality in such conditions?
Well, availability of vaccine is very much related with possibility for paying for it. And I think that is one of the issue. And you have the low-income country who may be available from getting funding from the Global Alliance for Vaccine Initiative, Gavi, and this are really making the vaccine available and affordable for the country, even if they may switch to having to reimburse some of the sum later on. But from the other, it's what is put up in the national level, how much of money you want to put in vaccinating people. And those vaccines are usually quite cost-benefit. It's not so always easy to show, but if you take into consideration the indirect effect of using the vaccine, that means you stop the transmission of the pathogen, and also now really considering all the impact on sequela, where really these sequela are costing the public health system a lot of money. So when you are taking all that in consideration, those vaccines are quite beneficial. Did I answer the question? I'm not sure.
Yes, yes, you definitely did.
May I
add something? Yes, please.
I would like to add my 2 cents. Variability is the point of the entire endeavor, the MenMapping, the meningitis mapping. It's like, so variability isn't something that is unjust or unfair. It's just the way, the serotyping, the genotyping that we do. We expect that there to be seasonal variabilities, regional variabilities. So, but the thing is, we need to provide people with what they need when they need it. And if we accomplish that, then there's no, then all is well in Fairland. Yes, thank you.
Okay, one last question, again, to be answered by any of the panelists who would like to add on. I want to go back to the beginning of our conversation and the strategic 2030 vision. How far do you think we are from achieving the goals of the 2030 initiative?
Is this question for me?
For everyone, but I see a smile on your face. I'm interested to see.
I can start, I can try. Well, as I mentioned in my presentation, I think it has been a number of milestones that was set up by the WHO. And it looks like half of them are already achieved or at least in very good progress. I think what is important is to keep the motivation. And we have now this vaccine. I'm sorry, but I believe vaccines are very important to really to have an impact and to be able to reach those goals, and especially for eliminating the epidemics. We have now the tools, and it's just to use them. But to use them, you need money. Some of the money is available, but it's also, Gavi is not going to pay for the whole world. So some government have to think about it and put aside money to permit vaccination. We have seen what happened with Haemophilus type B disease. It's very, very low now through the world because all countries except one, I believe, are really having the vaccine in their childhood vaccination program. And this can be achieved with many of the other vaccines. It will be difficult, as Mohamed mentioned, with MenB, because we don't have a universal vaccine yet, but still a lot can be achieved.
Thank you. Anyone wants to add anything on this topic? Yes.
May I jump in here? I totally agree with what Dominique just said about the importance of funding and money. We have the tools of many vaccines now, but I would emphasize on something, the surveillance. The pillar 2 of the WHO roadmap is really important for the not only diagnosis, but also characterization. And I take very simple example, which is Streptococcus pneumoniae. We have many vaccines now, 7-valent, valence, 13 valence, 15 valence, 20 valence. What is really important to see what is the best fit for your country, because the cost of these vaccines may vary, and you have to find a solution with the available resources that fit the best with your local epidemiology. So this is really very important to build a sustainable system of surveillance that would provide and inform decision-making process in terms of what is really going on in the country. Over to you. Thank you.
Thank you. So what I'm listening is data, collaboration, vaccines, advocacy, and the cornerstone is surveillance. And as Dr. Arish said, surveillance starts at the patient bedside. Yes, you want to add something, Dr. Arish?
I would just add, I think at this point of time, we need to rebuild the trust between the people and the government and the pharmaceutical companies. So we're talking about vaccinations and serotyping and genotyping, and we're doing it for the benefit of humanity. But especially with the most recent pandemic, there's a lot of naysayers and doubters around. So at this point, maybe the steps that pharmaceutical companies are already taking are positive, in the positive direction. But we need more to, again, to rebuild the trust that seem to have been lost recently. Thank you so much.
And again, which can definitely be addressed through advocacy and speaking about the topic, as was I concluded from you experts early on this panel. So as we approach the conclusion of our session, I want to reflect on what I heard most today. Professor Dominique has emphasized on the ongoing global burden of meningitis and the importance of coordination action under the WHO roadmap. And Professor Taha has showcased the MenMap's regional collaboration collaboration as a regional example and highlighted the progress and challenges of building sustainable surveillance systems. Dr. Arij has thankfully provided a valuable national perspective, underscoring both the impact and opportunities of engaging ministries of health in such initiatives. Together, these insights remind us that progress requires both global frameworks as well as regional adaptation that is anchored in strong national systems. So on behalf of INFNET, I extend our sincere thanks to our distinguished speakers and to all participants who have been very active in the Q&A and chat box as well. We encourage you to stay connected with INFNET's webinar series for future discussions, and we also advise you to refer to our published reports and materials, which can help address any additional questions and provide deeper insights beyond today's session. So this concludes today's webinar. Thank you once again, and goodbye. Salam.
Thank you and have a nice day. Bye-bye.
Thank you.